please. Okay, so let's introduce myself. I am Dr. Sayyid Zishan Javed Hashmi. I'm working as a consultant anesthesia at Prince Sultan Military Medical City. Um, I don't usually open the camera, but I would like to open it today so that all of you can have a look at me that I'm like you. I'm a human being. I'm not talking something which is not practically possible because unfortunately the way Neeta started, sorry, who's asked the question? Nawal, did you ask the question? I was sending the message, so I couldn't appreciate who was asking the question. Was it Nawal? Is it you?
Yes, sir.
Okay, so let us start. Am I visible to you? Just a second. Can you people see me? Is my video open to you?
No, no, no.
I don't know what has happened. Just a second, please. Just a second, please. I think. Okay. I think I will leave this thing for just a second. Can you see my screen? Is my screen or visible to you?
Yes, sir.
Okay.
Yes, sir.
Okay. So because the question which was asked to me that whether we should be studying from books or whether we should be studying from articles or whatever. So let me clear something that the concept which you are telling is not valid at all these days because now we have so many sources and you people are in 2024. Okay, so the ways of doing everything is changed. Maybe few decades ago there was no microwave oven and people used to warm the food on the stoves. Now we have microwave oven, so we don't use a stove for warming the already cooked food. Am I right? So same thing will be happening here. Another thing, this is one point number one, that you have to be in the era in which you are there at that time. Number one. Number two point is that believe me, whether you are appearing in anesthesia exam or whether you were in MBBS, the knowledge is the same. It's something very maybe you don't know before that in when I did my graduation in 1999, believe me, thyroid gland was in the neck and it was secreting thyroid hormone. And believe me, in 2024, it's doing the same thing. Okay, so it's something it has not changed. So whether you read from the book or whether you read from article, there is no difference. The difference only is that how much you absorb. So it doesn't matter from where you studied. The thing which matter is that what you understand and what you can reproduce and throw it on the other person. That's what matter. Okay, so from wherever you have studied, if you are able to reproduce it, it's fine. If you are not able to reproduce it, it means that you don't know. Wherever from wherever sources, the problem is that the books which you people are trying to study, the Morgan or any you name any book, is is not covering all the aspects of anesthesia. Maybe it this book reading is true for all other subjects, but it's unfortunately not true at all for anesthesia, because anesthesia is such a dynamic specialty that if you want to have a concept of 360-degree concept of a topic, you cannot get it in one book, unfortunately. Even articles are not perfect, but they are near to perfect because they are trying to cover that specific topic from the all the aspects. Okay, and don't try to read and cram and try to memorize each and every line. Okay, because in the exam, in few minutes I will be telling this thing, that in the exam there are basically two different sort of question. One is scenario based question or one is fact based questions. Okay, so one question will be that they will be giving you a scenario that xyz patient with XY disease for XYZ procedure. This is called a scenario based question. And the other question will be a fact based question, that what is monitored anesthesia care, or what is total intravenous anesthesia, or anything like that. That is called as fact based questions. And the other question which I told is scenario based. Okay. So the approach is the same, and they are only trying to listen from you especially in the scenario based questions. They are not interested in listening whatever is written in a specific chart or a specific. This is your perception, unfortunately. Or even, for example, even if it is in their mind that they want to listen 4 or 5 things, for example, it doesn't matter that you have read from anywhere. If you are able to reproduce that knowledge, you will pass that. I'm giving you an example which just struck my mind at the moment, myasthenia gravis. That if they want you to tell that in myasthenia gravis, which factors which will be leading the patient for the need of post operative ventilation. Okay, so I asked this question, just can you recall this question, that what will be the factors which are there in a patient with myasthenia gravis? If you find them, you will be thinking about post operative ventilation. Can anyone tell? Yes, please.
Sir, disease duration more than 6 months,
6 years.
6 years, sorry.
Okay. What else?
Pre-existing respiratory disease, any.
Very good.
Sir, dose of pyridostigmine greater than 750 milligram.
Yes.
7.2.
There will be two or one or two more things. So this is, I believe me, this is written in all the books. It is written in
Yes.
all the literature. It is written in every article. So it doesn't matter whether you are telling from, you have read from Morgan or you have read from article. They are asking a question, you have to tell them. Okay. So come out of this vision that you need to read it from some specific book. I have asked this question just for an example. Okay. So just try to open up your mind. If someone is telling you that read Morgan, and they will asking from the Morgan, maybe they are, I'm not saying, I'm not denying them, but their approach is wrong. Unfortunately, their approach is wrong, because they are making you in a hypnotism, in a fear that if you don't read Morgan, you will fail. I'm not saying that you cannot read it from Morgan. I want you to speak out the answer. I'm not interested from where you are studying. But problem is that if you are only thinking that you just switch on a button, and you are only listening that if they have asked a question, you have to open up the page number 75 of Morgan and you have to answer that question. This is wrong. This is the problem, that in the scenario. So I will be giving you few tips. I have already taken quite bit of time in giving this introduction. So I will be telling you the few tips which will help you in answering the questions. Because we have two different sort of people. Some are going for MCPS, some are for FCPS, and some are from other exams like me. There are some international audiences at the moment. So I will be trying to tell you, wherever you are, whatever exam you are preparing for, the basic concept is the same. The basic concept is the same, that first of all, if they are giving you any data, so I will be telling you the scenario based question to start with, and then we will be there will be some points related to fact based question. Yes, Zishan.
Assalamualaikum, sir.
Walaikum
Sir,
salam.
I would just like to add one thing that I can quote a few questions also. The people who like to only read Morgan and they think that only Morgan will lead them to the passing of examination, that is not true. There are questions that come which are not even mentioned in Morgan. So you have to study the articles and the other books which are for exam. Do not stick to Morgan alone. Of course, Morgan you can study as one part of your study, but do
Perfect.
not rely solely on Morgan.
Yes, perfect. Actually, even I'm not. People think that I have, I have some personal family rift with that gentleman Morgan who wrote this terrible book. I don't have any problem. I have only problem that when I used to read it, I used to fail so many times badly. And the time when I left it, then I came to know there is such a beautiful world to breathe in outside that bloody nonsense book. That's the problem. Unfortunately, that's why I'm a little biased about it. Okay. And the junior people who are like just hypnotized and telepathed by the people around them, read Morgan, questions are coming from Morgan, they are asking from charts from the Morgan. This is wrong. I'm not saying that you cannot answer because the thing is that everyone has got different absorption. Okay, not everyone will be absorbing everything they read. So the thing is that the business is and is that there is a the some people will understand hak to hak hai ke hak ada na hua. uh, that is the thing. Okay, that when the need comes and you are not able to reproduce it, it doesn't matter from where you have studied. Okay, so I will start this thing that whenever they are asking you a scenario based question, so what you should do, you should do that. Just a second please. That my suggestion to you will be that you should have a pen and a paper with you. If it's not there before they start the question, it's better if you can ask them, can I get a paper? And you just have a pen in your hand and just try to, like, they are giving you a data, a 75-year-old, they are saying a 75-year-old male, known case of hypertension and ischemic heart disease and diabetes, and now the patient is presented for TURP. Patient had a attack of syncope 10 years ago, and since then the patient has a pacemaker. Okay, so this is the data they are giving you. So how you can write that data? 75-year-old male, DM, IHD, okay, hypertension and pacemaker. You can write like this. This will take only 5 seconds. But what will happen when you will write this data? The thing will be that your brain will start tuning that these are the things which you should be having in your mind in next few minutes. Any question will be there, will be according to these things. And whatever they are asking, that the last thing is TURP. Okay. So your if you write these things in your front of you in your paper, in the paper, the advantage will be while you are writing, your brain will breathe and you will be able to recall the things about these things, about these diseases. Okay, so this is the first point to remember, that try to write whatever they are asking, but not in full form. This is shorthand. So the advantage will be that you will be able to, you will not miss anything, because in the exam anxiety you can easily forget. So this is the tip number one. Tip number two is that now you have to expand. Now, what is the difference between table viva and a long case? The knowledge is the same. uh, Beautiful baba can be there in the long case, same, with almost same problems. The only difference will be that in the long case, you have to ask the history, you have to do the examination, you have to ask for investigations, and then you have to chalk out a data which will be presentable to the long examiner. And you will have to tell that what are the problems, and they will be asking you some questions about the disease, and then they will be asking you how to conduct the anesthesia in that patient. This is only difference here. Table viva, this is like a roller coaster. You have only 5 minutes, and whatever they will be asking you, will you have to answer in next 5 minutes. They will be asking you everything in a way that if you don't have any lack of concept in any point, you will not be able to answer. Okay, so I hope I will request all of you to mute your mic. And at any point, if you want to ask any question, you can raise the hand and I will let you ask the question. So my request is that please, can we note down during interview via meetings? Yes, definitely you can do it. Okay, so you can do it. So this is point number one. So in next 10 seconds, you will write down what you want to ask. And after that your approach will be in table viva. Please don't say I will take history, I will do examination, I will do this, I will do this. No, there is no time for you to answer these terrible words in table viva. You will be saying the word which I'm writing in next few minutes. You can quote it in any scenario base, that I will evaluate the patient. You can use this word, evaluate the patient on the basis of history, examination, and relevant investigations to see how much is the end organ damage. If you speak out this word, it will cover everything. And then they can ask what history you will ask. Then you can focus that if there is a prolonged history of diabetes uncontrolled, there will be chance, there will be something happening which is the microvascular and macrovascular complications. So your answer should be, if they ask, usually they will not ask. If you tell like this, that I will be focusing on the history, examination, and relevant investigation to see how much is the end organ damage because of diabetes, ischemic heart disease, and hypertension. And as the data which they have provided to you, you already can see that there is pacemaker. So there is already some sort of ischemia which has already been done, resulting in some arrhythmias, resulting in the need of pacemaker. In this specific scenario, you can extract this thing easily. Okay. But if you don't prepare this question, the pre-hand, this answer pre-hand, unfortunately, you will be just like without knowing any know-how of swimming, you are in the sea, trying to learn swimming in the sea, if you don't prepare. So again, the rule number 2 is that the common scenarios and common conditions which they are asking in almost all the exams, you should prepare pre-hand. Okay. You should prepare pre-hand these things. So what will be the common things? Will be like pregnant patient, elderly patient, smoker. Okay. Then pediatric, in pediatric specifically a neonate, a preterm. Okay. And a kid. Then alcoholic. Okay. Then you can add on few more, opioid addict. Okay. Then you can make few group of people which they can ask you. So what is there in our scenario is elderly. So this is an elderly patient. Okay. So this will be thing that this is, and you will be telling that this is an elderly patient. So the answer which you can make, same answer will be for pregnant patient, for pediatric patient, that there are altered physiological, pharmacological, and anatomical considerations and predisposition of specific diseases in that specific predisposition of specific diseases or specific challenges in that patient, which you can quote whatever you have. If you have elderly patient, if they ask further, you just have to tell them the buzzwords, and whatever they want to ask, they can ask you further. They are not taking viva on elderly physiology, I can guarantee you. They have so many things to ask. So in this scenario, even only if you tell them that there are altered physiological, pharmacological, and anatomical consideration leading to challenging anesthesia conduct, that's it. Okay. This will take only 5 or 10 seconds to tell you. Same word which you will say, there is a pregnant patient, so there are altered physiological, pharmacological, and anatomical considerations which will be making the anesthesia conduct challenging. So you can use this word in anything which I told you. Okay. I have made so many lists of the thing like that. You can, all of you are welcome to contact me anytime. I'm available to all of you 24/7. Okay. So this is the another point which I'm telling you. Another thing, if you're any one of you try to cook mutton karahi at home in 30 minutes, you cannot do. But when you go to a restaurant, they can make it in 30 minutes. Why? The difference is that they have already half cooked and prepared all the recipes which are needed to prepare that food. So you have to use the same concept in your table viva. Same concept. The same concept will be there, that you should be knowing that there are microvascular and macrovascular complications and how to rule out them. You should be knowing that. For instance, if I'm just telling you one example, and you can make this for the all, that if you want to see whether there is microvascular, macrovascular complications, for example, involvement of heart. So what you can that there will be chances of silent ischemia. Okay. So the things by which you can tell will be the ruling out anything of ischemia, like in the history, There may be some sweating. Usually there will be chances of silent ischemia. Okay. But still you will be able to find out some things in history, and then some things in examination, and some things in investigation. Like you can have a resting ECG, or if the patient's physical activity is not good, then you will be going for stress testing. Okay. So this question will be further elaborated once you will come to know that what is there in now I am telling you the highlighting the problems as well. They are not interested to tell you the details of diabetes mellitus, okay? But because it's in your mind that you have found a diabetes mellitus, you are trying to tell, I will take history, which medications he is taking, which medications he is not taking, how is compliant. This is not an answer for you, my dear. If you tell like this, if they want to know the details about diabetes mellitus, they will ask you. But actually, in such a complicated scenario, there are so many points they have to ask you that they don't want you to tell the details unless it's in their mind. And if they're in mind, you tell the buzzwords, and if they want to explore, they can explore you. Okay. So this is my request, that you have to gather the information, and you can tell and even in you can even squeeze further, that you can say that there are microvascular and macrovascular complications because of diabetes as well as hypertension. Okay. So it will be resulting in either in CVA, it will be resulting in ischemic heart disease, atherosclerosis, peripheral vascular disease, involvement of heart, autonomic nervous system, leading to gastroparesis. This thing, if you don't practice, you will not be able to explain. So, diabetes, ischemic heart disease, hypertension, and some other common diseases, this should be on your tip, because unless if you don't have a very good practice, you cannot answer it in few seconds, because you have only few seconds. And if you are stuck in diabetes mellitus only, you will fail. Definitely you will fail. Why? Because they have to ask you so many things. There will be so many things about pacemaker. There are so many things about TURP. Okay. So this is my request to you, that make your approach like this, that what they want to you to listen in table viva. They are not interested in too much details unless they have made up their mind. I hope this point is loud and clear to you. Okay. So specifically with reference to pacemaker, what thing you have to speak out? What was the reason for pacemaker? Is the pacemaker working? Is the pace after pacemaker the problem is resolved? Okay. And another thing, that in the perioperative period, you have to avoid the factors which can create problems with pacemaker. So ideally, you will be contacting the manufacturer, and it will be better that he will be looking at the pacemaker, and they can put it on fixed mode. Okay. And there will be certain things you will be taking care, that anything which can change the threshold potential, you will try to avoid. There are some other points with reference to electrolytes, with reference to use of diathermy. And ideally, you can tell that if the modern pacemakers are actually AICD. So they have two functions. They have defibrillator function, as well as they have the pacemaker function. Okay. So you can tell that there should be you will attach the pacemaker pads, number one, sorry, the defibrillator pads, and there should be ideally there should be facility of temporary pacing in case the patient needs intraoperative pacing. Okay. So your answer will be finished in these 3-4 points. Okay. And you can make it also as a like in the list, you can also add pacemaker here in the list. Okay. So this is what. Then with if the elderly thing will be finished and the diseases will be finished, that the last thing will be the surgery. So any surgery, you should be knowing what are the approaches, not in details that you have to open a scalpel and you have to do a surgery, but basic things. Okay. Like in TURP, what can be the problems? What can be the complications? In TURP or any other surgery, you should be starting. What are the reasons for that surgery? What are the complications which can occur in the surgery? Which position the patient will be in when they are doing that surgery? So they immediately they will not ask you, please can you tell the problems with the lithotomy position? No, they will not ask you. You have to tell that this surgery will be done in lithotomy position. So you will be ruling out any limitations in the physical joints or anything, because this gentleman will not be running like Imran Khan. Okay, he will be not be old man like him. He will be a different old man. Okay, or he could be a different old man, and he can have a physical limitation in lithotomy, making lithotomy position. Okay, so then you will be telling, and there will be any not only in lithotomy position, any positioning which will be there. So there will be three steps. One will be the initiation of that position, the effects after initiation, and or you can say maintenance of that position, and then the third will be the reversal of that position. So you can use this concept for any positioning. Same thing will be more in lithotomy and prone, but it is there in lateral position. It will be there in Trendelenburg position. It will be there in reverse Trendelenburg position, or any position. Okay, so all the things you should be known, and you don't need to tell, sir, there are chances of nerve injury. No, they are not interested to listening to you. Yes, but you have to use this word, that you should be taking care while positioning, initiation of the positioning, and the problems which can there in the maintenance of that position, or when they reverse it. Then if they want to ask you further details, they can ask you that when you lift the legs, there will be auto transfusion, patient can go in overload, or there may be dislocation of the joints. If the patient is there in lithotomy for a long time, there may be nerve injury, etc., etc., etc. Okay, you all of you know about it, but problem is that you are not able to reproduce this thing because you are not doing any practice, because you are in, again, I'm sorry, I'm very biased about it. So because you will not find this thing written in your bloody Morgan. Okay, you will never find these things written in your holy Morgan, Manhus Morgan Sharif. You will not. So if you want to you breathe freely, if you don't want to suffocate yourself in a dirt track, you have to come out of it. That's it. Okay. So positioning, and again the complications. Some complications will be there in the intraoperative period, and some complications will be occurring post-operatively. Okay. So TURP, very quickly you can tell that there will be something with relation to positioning, as I mentioned. Then some surgical problems with reference to bladder perforation, with reference to overstretch, and with reference to hematoma, hemorrhage. Okay, and the other things will be related to the fluid they are using. Okay, so fluid will tell that what are, because now these days they are doing it even laser. There is recently they are doing it with laser, and there is no problem at all. Okay, but the only problem which will be that it's laser TURP usually occurs for a long time. Okay, and like all these problems will be for a prolonged time. This is the only thing. Otherwise, all the problems which are there with the TURP syndrome and anything, they will not be there. Okay, so this is another thing. Then practical problem they can ask about this, because usually they can ask you further questions about it, GA versus spinal. So you should be thinking, you should be telling before them that we can choose either of them, but these will be the problems with GA, these will be the problems with spinal. There nothing there is safe. So you can say, this is also a word which you should always cram, that you have to outweigh risk versus benefit. I have to outweigh risk versus benefit. There is nothing with halal or nothing with haram. There is nothing like that. You just have to prove. If you are a man and you are not able to prove that you are a man, you will fail in the exam. And if you similarly, that if you are not a man but you proved in the exam that you are a man, you will pass in the exam. So whatever you commit, you have to prove it. That because I'm using GA, these are the reasons, 1, 2, 3. That's why I'm using it. If you tell about spinal, you can tell that there are so many advantages. Patient will be awake. Patient, if any sort of neurological involvement occurs because of hyponatremia, you can pick it early. Okay. Similarly, there are so many things which you can elaborate. That if the bladder is perforated and you had given a very high block, maybe the patient you will not be able to pick it up in spinal. Okay. So in GA, when the patient is awake, maybe the pain will tell, and you can pick the bladder perforation. Otherwise, this is maybe not your concern, okay, but it can occur. So another practical problem is with reference to erection. Another problem similar to TURP is TURBT. So that is needing the obturative reflex, how to plant it, okay, and what are the complications which can occur with this obturative reflex, okay. Can you mute yourself, please? Okay, so up till now, what I have told you that how to do a hierarchy of any question. This scenario can be changed to any scenario, but your approach will be the same. So that's what the page which I had showed to you when I started. This is how you should be approaching. So now I will be summarizing or telling you what I told you a few minutes in the previous 20-15 minutes. So this is with reference to disease, and this is with reference to conduct of anesthesia. So you can have a look at it, and you will. So what you have to do, you can, because this is, I have not copy pasted it, I have just wrote it with my mind. I have just think, and I have make this document, and this is not perfect. I don't claim that this is the only paper which can may pass you, or I cannot tell you that this paper is with the CPSP key. No, I'm just telling you an approach. You can add it, you can make it your own. That whatever the disease is, what is the main category, what is the pathology, what are the mechanism of problems, and you think any disease. Rather, I will tell you, make a list of common diseases in every system and try to fill up this paper. Okay, so what will be the advantage? That you will be able to tune yourself, and your answer will be prepared, and as soon as the examiner is opening the mouth, you can put a carrot in their mouth with your answer, and they will be shut up. They will not be able to ask you further questions. Sorry to use a bad word, but that's a reality. That if you, in any fight, the first punch is the most effective one. If examiner start asking the question, and you punch him so hard with your answer that he will not be able to stand, and he will not be able to fail you. So this is the what I am trying to make you understand. Okay, so similarly, how to diagnose the disease, what is the evaluation, and estimating the severity of the disease. You can fit it in any disease. And then you have to, I'm really distracted by the mic. So please, I request you humbly to mute, keep your mics muted. Okay. Okay. So then, with reference to, because our whole shop relies on airway and cardiac and respiratory and liver, all the medications are affecting liver and kidneys. Okay, and bone marrow is related to our cell lines. So these, and then the homeostatic condition. This is not hemostasis. This is homeostasis, the acid base balance, the electrolyte and fluid. So just think about this. Maybe you can add a lot of things, but this is just an idea that whatever topic or whatever disease or whatever surgery you try to see, is there any problem with the airway? Yes, diabetes mellitus, the famous airway problem with reference to opening of airway because of glycosylation, which we are reading since our birth, the prayer sign. Okay, but this thing should be in your mind only. Okay, so you will be able to chalk it out. Similarly, diabetes mellitus, cardiac. Okay, this gentleman can have autonomic problems. This gentleman can have atherosclerosis leading to peripheral vascular disease or cerebral vascular disease or ischemic heart disease. Okay, I have to rule it out. I have to see the functional capacity. I have to see whether there is any history of TIA or stroke, or there is any intermittent claudication, or there is any autonomic neuropathy with reference to orthostatic hypotension or gastroparesis. Okay, you will have a look on the ECG. So, but you don't have any time to tell all these things in the table viva. So you will just say, I will make sure there is no, this is very irritating for me. I wish that I became resistant and don't respond. Like atropine does not affect the denervated heart. I try to be denervate myself. Anyways, so similarly, the next part with here is that the all whatever, try to find out the cardiac risk, the pulmonary risk, the renal risk, the aspiration risk, the PUNV risk, the airway management. The special monitoring needed in addition to AS and standard monitoring 1 and 2. So like for example, in this scenario, if someone wants you have to tell what you have to tell, that this patient might need, in addition to standard 1 and standard 2 monitoring, this patient will be needing invasive blood pressure monitoring. This patient might need cardiac output monitoring. You can tell that if you have the facilities. Yes, I have not used it, but in this scenario, the patient is having pacemaker, and if there is the cardiac function is depressed, and then you are interested in looking any decompensation and any overload, yes, you can say that if there is possibility of having cardiac output monitoring, this will help. Okay. So this is how you will make your answer. If you have a neuro case, you can say that this patient, you will be having neurophysiology monitoring. Similar, you can open your brain and just see anything extra than ASA and standard 1 and standard 2 monitoring. This may be urine output, this may be temperature. Temperature, by the way, is a standard 2, but you can add anything. There may be airway pressure monitoring in patients with the COPD, the nerve monitoring. There is difference between nerve monitoring and neuro monitoring. Nerve monitoring occurs in any surgery in which their surgeons are doing any surgery, any nerve is passing by, like mastoid surgery, parotid surgery, thyroid surgery. Any nerve is going, recurrent laryngeal nerve, facial nerve, they are doing the neuro monitoring, so the nerve monitoring. Okay. So this is with reference to monitoring. And similarly, blood transfusion related. So if any patient which can bleed a lot, you can say that I will be mentally prepared for any need of blood and blood products. Remind it, technically, internationally, there is no concept of blood transfusion. There is always concept of blood products. So PRBC, FFPs, cryoprecipitate, and then further the atomic bombs like Novo 7 and things like that. Okay. So, and another thing which because it's not available in our country, so we are not aware too much about it, that is cell saver. And another thing which is not available here is thromboelastography. Another thing which is we are not doing regularly is INR. There is bedside INR, there is bedside ACT, thromboelastography. Don't try to tell all these things immediately unless it's not needed. Just keep this thing that we might monitor, we need to do. A beautiful word you can use is we might need to have point of care testing for to look at or to evaluate the extent of bleeding, and to monitor or guide the replacements. This word you can use it any answer, that I will be monitoring through, of course, the surgical site and drains and everything. These are the extra things which you can tell, and they will be surprised. They will be like you have. Uh, you don't need to bring carrots with you to put it in the mouths of the examiners. This is the carrot which you will put when you are be answering like that. Okay. So this is what I want to do. So similarly, you can make, and then when our shop, anything with reference to pre-medication, like for example, a patient is having a risk of aspiration or PUNV or anything like that, you will be doing some pre-medication. You will be thinking about monitoring, as I mentioned, and induction agents. Whenever you are answering any question, think propofol you can use or not, thiopentone you can use or not, ketamine you can use or not. You don't you do, Also etomidate is a crap medication, and if you are a good anesthetist, you need to use etomidate. But in the exams, whenever you see any cardiac patient, please don't hesitate to tell about if etomidate is available. You have to tell, though practically I never use it. It's available in our hospital, we don't need to use it. If you are a good anesthetist and you know how to do the titrated induction, you never use it. But in the exam you have to tell. Okay. So similarly, muscle relaxant, can I use atracurium, can I use cisatracurium, can I use vicronium, can I use rocronium, things like that. So you should have a practice. If you practice this paper with all the diseases, believe me, the exam will be a piece of cake for you. I can bet about it. But if you are only reading page number 75 of Morgan and on because and you are also moving like madrasa students, they are when they are trying to memorize anything, they are moving their head ups and down. So if you are just trying to cram the words of Morgan, it will deceive you, like a beautiful girl can deceive any simple guy who doesn't deserve her. Okay. So Morgan is not a good book. It will damage you in the exam, and because you are not able to construct your answer in the scenario based question. So that's the only thing which I am again and again telling, that it can deceive you very badly, because in the exam they want you to tell these things. Okay. So similarly, one two things I missed is with reference to logistics. Okay. So logistics will be, if you have an oh my, I'm really sorry, I forgot to tell about obesity. Obesity is also in this list which we made. Obesity is the cheerleader here, because every now and then there will be an obese patient. So with reference to logistics, you will be thinking that what extra thing you need: extra monitoring, a special temperature in the room, logistics with reference to need of blood and blood products, logistics with reference to difficult IV management, logistics with reference to ultrasound, anything you think that you need extra, you can tell. Then after operation, where you have to send the patient back home, you have to send the patient to the ward, you have to send to the patient to HDU, you have to send the patient to ICU, you have to keep the patient ventilated, you have to take care of certain things. Okay. You have to start something post operatively, you have to keep something intraoperatively. So everything should be in your mind. If you have a patient with insulin dependent diabetes mellitus, the thing which you should be telling, that there may be need of insulin infusion, there may be need of electrolytes, there may be need of frequent blood sugar monitoring. Okay. So I'm just giving you example. I'm not teaching you any topic specific. I'm telling you the tricks which if you apply to any topic, you will pass. Okay. So I hope you all are with me and you are not getting bored. Okay. All of you are alive, or am I talking to some machines? So just let me know that you are awake. And anyone have any question up till now? Just let me know. Any questions, please? Okay, so I will just try. So this is, I have just made sort of mnemonic or a summary, that evaluation on the basis of history, examination, investigation, risk assessment and risk stratification, optimization of medical condition. This is the thing which they will be asking, that if there is an elective case and you need something to be, so your answer additional point with that, if there is end organ damage, up till that I told you, you can say anything which can be optimized according to the urgency of surgery. According to the urgency of surgery, if anything can be, or any medical condition can be optimized, you have to mention that thing. Like, for example, if you have a patient with COPD and the patient is undergoing elective cholecystectomy, there will be certain questions you need to answer, whether they are doing it open or laparoscopic. This will be question number one. Number two, because this is actually, cholecystectomy is never an elective procedure. It's a planned procedure, because you cannot delay it. Elective procedures are cosmetic procedures, the joint replacements, the bariatric surgeries. These are usually, sometimes they can be considered as elective procedures. Otherwise, certain surgeries are never elective. They are called as planned, but practically you say it as elective. Okay. So similarly, not all surgeries are emergency, because emergency cesarean is, for example, fetal distress, firearm, expanding extradural hematoma. These are like sort of, this is just an example of emergent surgery. Practically, emergent surgery should be done within minutes. Urgent surgery should be done in hours. Elective surgery, planned surgery should be done in days to weeks, and elective surgeries can be done in months to year. Okay, so this is the order: minutes, hours, days, weeks, and months. So this is the order. So according to the urgency of surgery, how much optimization you can get is an example, that if you have some time, you can give some bronchodilators, you can give some antibiotics, you can do some chest physiotherapy, you can drain some pleural effusion, you can add some bronchodilators or steroids, anything to improve uh, the outcome. Okay, you can change the mode of the surgery. If there is always a debate because open laparoscopic, open versus laparoscopic have always risk versus benefit. If you do an open, maybe intraoperative course will be better, but post-operative course will be bad, because post-operatively patient will have pain, the patient will have more splinting, already CO2 retention, more CO2 retention, more problem, and it can result in patient going into the ventilator post-operatively. So there is no an laparoscopic surgery for COPD patient. Maybe intraoperatively you need to be careful. If you because already airway pressures will go high, and if you are not able to handle it, there is emphysematous bulla, and you manage to have a postoperative pneumothorax. Okay, so these are the things which you. But again, remember one thing: always use the words like the bloody plot politicians, risk versus benefit. I will be evaluate the patient which is better. I will discuss with the surgeon to see what is his priorities. Okay, so you don't have to say anything halal or haram, because there is nothing halal or haram in medical science. You always have to say, I will do the risk versus benefit. This thing has this benefit and this thing has this benefit. So you should be answering like that. Okay. So similarly, I have written this thing last, but because the people, they are interested in, sir, I have pre-operative, intraoperative, post-operative. I have to tell like that. The thing is that if you are able to answer this nicely with this approach, preoperative, intraoperative, post-op, okay, fine. But the problem is that the only the trouble is that sometimes if you are trying to answer 100%ly with this approach, sometimes you are stuck. Sometimes, unfortunately, you are stuck, and maybe something you can tell. Believe me, majority of the things you can tell preoperative. Majority of the things, even up to use of any medications or anything, you can tell in preoperatively. It is better that you will be prepared for this thing. You can use this word that I will be prepared for this thing because this patient will be needing this thing, this thing, this thing. And postoperatively, whatever you. So don't overdo this preoperative, intraoperative, postoperative. You need to tell them in quick time without missing anything. So if don't overdo, again, I'm telling you, don't overdo. You don't need to follow this protocol 100% in every patient. Maybe some patient needs a lot of preoperative. Some people need a lot of intraoperative. Some cases need a lot of post-op. So try not to miss. Okay, and don't burdenize yourself. Only that I have to tell 100% this thing you can miss. So I'm not saying that this is wrong approach. That's why I've written it here. But try to be logical. Try to understand the situation. Okay. So patient related, disease related, surgery related, preoperative, intraoperative, post. Okay. And with reference to surgery, I have already mentioned surgical urgency and then surgical risk. What are the surgical risks in that? There may be apparently a low risk surgery, but there may be some critical step, like you are doing an incision drainage near groin. This is a low risk surgery. But what's the problem? There are some major vessels around it. So suddenly patient can bleed. So even a low risk procedure suddenly can bleed. And these are, that's why I have written one, bleeding risk and surgical risk separately. So cesarean section is not a high risk surgery, but it's a high risk for bleeding. Cesarean hysterectomy, sorry, uterine bleeding is one of the nightmare for any person. Okay, so you have to tell that it's a low risk, it's an intermediate risk surgery, but it can bleed a lot. Okay, so again, level of incision, level of anesthesia required, possible anesthesia option, possible, always don't miss analgesia options. So multimodal analgesia should be your approach, and you multimodal, and then you can use the word that I will try to block the pain sensation at all the steps. Okay, the transduction, the transmission, the modulation, the perception. I will try to block and all the 4 steps. Okay, so this should be your approach for the table viva. And mind it, some people will be asking long case. Believe me, there is no difference if you make your approach that what you say, the word paki pakai kheer, already ready made food. Okay, so in table viva you will have a paki pakai kheer, ready made food, and you just have to just garnish it and present. So this is difference between table viva and long case. When you are asking the question to the patient, your mind should not be listening to the star plus story of the patient, because that baba or that lady can distract you very badly. Okay, so try to focus on your shop. Don't try to be distracted by that person. Whatever you are asking, there will be one thing which will be the history of presenting illness or presenting complaint, and the other systems will be the same. Actually, I have just let me show you. Inna lillahi wa inna ilaihi raji'un. Yes. Like Just a second, please. Okay, so in let it it's open, and let me show you something. Okay, so these points are for long case, but mind it, this is true for you as well. Have a look at it, because anything like if you come to know that you have a patient with myasthenia gravis, or you have a patient with anemia, you have a patient with sickle cell disease, in the history examination, they can you like you use this word evaluation of the patient on the basis of history examination and investigation. So in with this chart, you can see that what are the things we are asking. So in the sorry, in the long case, whatever patient comes to you, my request or my suggestion to people are going to have a look on the different sort of patients. In the exam, you don't know which patient you will receive. Okay, and you cannot cover all the patients. Okay, then another point will be that you cannot predict that how sweet that person will be. Maybe that person is very cooperative, maybe the baba is very angry, he's not answering to you, he's short of words. Okay, he's not able to understand, and maybe you are not able to talk to him in the language he is understanding better. If you are doing Urdu of Lucknow to Babaji of Faisalabad, maybe he's not understanding what you are saying. Okay, so these things, but the common thing will never miss, that you have to evaluate from head to toe, and you have to evaluate all the systems, and you have to think about all the anesthesia steps: induction, maintenance, recovery, nerve block, analgesia, monitoring, etc., positioning, everything. Okay. So, whatever history you are asking, you should be knowing why you are asking that question. Okay. So, my suggestion to you, this is not, again, this is not 100% thing, but you can make your own. That even if you, instead of a human being, you receive a horse in your long case, so you should be knowing that even with the horse, you have to look at the horse in the same way. Okay. So this is my suggestion to you, that whatever case comes to you, the only problem with the patient will be only one thing: the presenting complaint. The rest of the things you should be evaluating all in all patient the same approach. Maybe you will not, like, yeah, you find there is no need for neurological examination, but quickly you can think sensory system, motor system, higher mental functions, and reflexes. In four things, you can say the patient has no neurological problem, sensory system is intact, motor system is intact, higher mental functions intact. That's it. And also, sorry, cranial nerves. Okay. So this is one example. The same thing you will be asking in the history, the same thing you will be doing in examination, the same thing you will be doing in the respiratory system and this approach should be the same. Like if you want to rule out liver, even if you have a patient with diabetes, you can ask 3 or 4 questions to rule out liver. Is there any nausea, vomiting, diarrhea, abdominal pain, hematemesis, melena, etc., etc.? Finished. Okay. So you can make a list of the 10 questions or 10 examination point for liver, 10 points for kidneys, 10 points for heart, 10 points for anything. Okay. So this is my suggestion, that make your own. This is, again, this is, I have written, this is not a perfect thing for you. Maybe you can make your own, but when you are in the examination hall with the patient in long case, don't waste time, because the mistake which people do, they don't prepare this thing and they are asking question from the answers of the patient, and this they the that the patient will become like a shaitan and they will take you to the hellfire. I can guarantee you that if you try to focus only on the questions on the basis of the history which you get from the patient, you will be lost. So the only thing you have to rule out with that way is the history of presenting illness, and ruling out anything in detail with reference to that history, how the patient comes, what happened to the patient, what medication patient is taking, etc. But the other things will be the same. Okay, I'm highlighting again and again the importance. And again, my dear, at the end of the day, when you are finished with your history examination and you are in front of the patient, the examiner, believe me, there is no difference between a table viva and a long case. The only difference is that then in usually in the table viva, they are not asking you what are the microvascular and macrovascular complications and how they occur.
in diabetes and ischemic heart disease, but in the long case, they will ask you that how this it occurs, how hypertension develops, what is the classification of hypertension. So the pathology part or physiology part or pharmacology part or mechanism of actions of drugs or side effects of the drugs, usually they can ask in the table viva as well, but usually they are not asking this thing in table viva. They are asking these things in the first 15 or first half of the disease part in that patient. But if your aim is, if your objectives are clear, you will never be in trouble. Okay, so whenever whatever history you took history, examination, investigation, chalk out what are the cardiac risk factor, pulmonary risk factor, what is the ASA status of the patient, and what problems you will face in induction, what problem you will face in maintenance, what problems you will face in recovery. Is there any need of PONV prophylaxis? Is there any risk of aspiration? Is there any chances of difficult airway, difficult IV lines, difficult communication with the patient? And you can make your own list, and when you are in the front of examiner, it will be very easy. Okay, another thing which I missed in while when I was telling, that try to prepare a 1 line 1 minute or very short answer to all the disease. Like I give you an example of myasthenia gravis. Again, this is because I have taught this thing multiple times, so unfortunately it comes to my mind and I'm able to explain the concept of this 1 minute or 30 seconds answer for a disease. What is myasthenia gravis? They can ask you, or even they will not ask you. They will only give you data. If the patient is myasthenia gravis going for elective cholecystectomy, how will you give anesthesia? Okay, so you can say that myasthenia gravis. You can start your answer in 30 seconds like this. Myasthenia gravis is an autoimmune disease. So, and the other thing which I told you with reference to the disease duration. So you can say that it's an autoimmune disease affecting the neuromuscular system, and because of postsynaptic destruction of acetylcholine receptors, there is weakness of muscles. Okay, so this is one part of it. The other things will be the patient is taking certain medication which can disturb the anesthesia conduct. There are chances of aspiration, there are chances of post-operative ventilation, there are chances of utter autoimmune disease. Patient is taking steroid, so I have to respond to it. This is, you can make your answer like that for all the diseases, the common diseases like anemia, like diabetes, hypertension. You can make a list like hemophilia. Maybe in some disease one system will be involved, in other disease multiple systems will be involved, but the approach and the theory is the same. So again, my request will be, make a list of all the diseases you can come across and make a 30-second to 1 minute answer which you can immediately tell to the examiner. Okay, no details. You don't need to speak in British English. You can speak in any language which the examiner can understand. There is no problem. Right now I am talking in English because there are some international audience as well, but usually you can speak in Punjabi and you can speak in Pashto. If the examiner is understanding that thing, he will not mind. Okay, of course this will not happen, but I'm just telling you that anything, if you are not able to explain in very good English, don't hesitate to speak in Urdu. Speak out in the language the examiner will be able to understand. So this is the basic thing which should be knowing how to approach an exam. Table viva, long case. And again, in any case, usually they are asking about some critical incidents. So this is again in your approach, that when you are dealing any, like in a patient with myasthenia gravis, the critical incidents, can be the critical incidents? Critical incidents may be aspiration. Critical incidents may be prolonged effect of neuromuscular blockers. Critical incidents may be delayed recovery. This is, I'm just giving you an example. So similarly, try to have a knowledge again with the disease. Diabetes mellitus, what can be the critical incidents? Intraoperative hyperglycemia, intraoperative hypoglycemia, difficulty in intubation, sudden changes in blood pressures, sudden hemodynamic instability, thak blood pressure down, thak blood pressure up. Anything can occur. And then or other system you can see, post-operative renal failure in a or patient with already impaired renal function because of nephropathy. And alhamdulillah, you gave a good dose of NSAIDs, and alhamdulillah, you did not give good fluid, and you also they used a contrast. Okay, So these factors will increase the chances of postoperative renal impairment. Okay. So this is also a critical incidence. Similarly, renal failure patient, the critical incidence is what is the same thing you can think about it. Gastroparesis, aspiration, coagulopathy, azotemia and uremia. For patient going in uremia. Similarly, liver failure, bleeding, intraoperative. So always make a list of critical incidences. Okay. For with reference to all the surgeries, with reference to all the diseases, because this is the business end where from wherever you have studied in the exam, they want you to tell them what are the problems that you will be killing the patient, or what can be the problems which can occur in that problem may be surgical. Like for instance, if you are doing a neurosurgery, bleeding can occur, or neurological injury can occur, intraoperatively air embolism can occur. Okay. You are using TIVA, so TIVA related problems. You are using hypotensive anesthesia, postoperative neurological problems can occur, postoperative renal failure can occur. So you have to think about that case. If you are able to think about that case and answer in that way, believe me, there is no problem. And these answers, I can bet that you will not find in your holy book. You will have to discuss and discuss and discuss. Okay. So I think I have taken a good bit of time to explain. Any questions you want to ask? We will have some more sessions with specific disease, but remember one thing, I don't want to make you people a drug addict. Okay. That you are only listening to someone and only doing what he is telling. Whatever I have told you, you are free to have a counter argument with me. I will be very happy to be corrected. Number one. Number two, I want you to use your brain rather than I'm giving you addict medication that read these notes and read this source and you will be able to answer. There is no perfect book. There is no perfect source. You should be knowing the way they want you to answer. Okay. So I hope you people are with me. So before I finish, any questions, anything you want me to tell, or any comments or anything to be added or anything which I missed, you all welcome. The approach is the same. So where is the lady which asked me the question in the start? Is she is still alive here? Yes, Nawal. So did I answer your question? Is Nawal here? Nawal Munir.
Yes, sir, I got the answer. Thank you very much.
Okay, so anything so a few things I just want you to show you this with reference to testing. You should be knowing why you are doing that test. Like for example, what information you will get from CBC, what information you will get from LFTs, what information you will get from urinary. Anything you can tell, but you have to prove why. Not like, sir, I will do the routine investigation, I will do the baseline. There is no concept of baseline. Okay. Any investigation, you need to tell the reason. Hemoglobin, to see the initial hemoglobin, and patient might bleed. This may be the reason for hemoglobin, because a patient is a cardiac patient, so I need to maintain a certain hemoglobin level to have a good oxygen carrying capacity. This will be the answer for reference to hemoglobin. WBC, okay, I just want to see any element of infection, because patient is undergoing this surgery and with this disease, and there may be problem. Similarly, platelet count or coagulation profile or electrolytes or liver function test, or you can prove anything. Any patient taking antihypertensive medications can have some side effects. Any patient taking anti-epileptics or anti-asthmatics or anything, you can whatever you are telling, you should be knowing the reason. You are doing ECG, why? You are doing echo, why? Okay, like you can prove echo. Patient is going for an intermediate risk surgery. Patient is having limited functional capacity, or patient is having joints problem, so I cannot assess the physical activity. And patient is having risk factors like insulin dependent diabetes mellitus with intermediate risk surgery, and you are not able to assess the physical activity. So now there is indication for doing stress echo. Okay. So similarly, you should be knowing. I have, by the way, because before I used to take a lot of sessions, all of the information is there in the YouTube. And I believe me, I don't earn from YouTube. So my humble request to anyone who is listening to me, I just want to spread the message. I love anesthesia every day more than yesterday. I respect and I want you, all of you, to be anesthetist which can treat your own mother, who can give anesthesia to his own father. Okay, exam is, take exam on the toe of your feet. Don't worry about exam. Exam will is not a problem. The problem is that to be a good doctor, to be a good anesthetist, to be a safe anesthetist, problem is that you people only try to pass the exam because you people are fed on this approach. Knowledge will take a lot of time. You can take knowledge anytime. Pass the exam. Yes, this is fine. I'm not saying that you should not try to pass the exam, but why your approach is wrong, why your intention is wrong. If your intention is not to be a good anesthetist, only to pass the exam, there will be no barakat. I can guarantee about it. So try to whatever you are doing, try to be logical. Okay, list of what, how we learn. Can you resume? What was the point? Resume for a step by step to take
A list
consultant.
of topics. A list of topics.
Pardeep,
The
now you have not, because I can twist your ears. You are in the, you have listened to me a number of times. I have, you know the link, you have not seen it, unfortunately. List of topics. There are so many topics list you have never seen. You have never opened the link, unfortunately. That's why you are asking this question. Okay. So there are so much material in this, you see topic wise questions. So there are so many topics. And another thing I want you to tell, to be known, that please don't think that SAQs cannot be asked in the table viva. SAQs based questions can be asked in the table viva, believe me, because the knowledge is the same. So if you want to have a topic wise, I have made a lot of questions myself, and there are so much here. Open it and try to solve the answers. That's it. Okay. And then I will be asked a question, sir, from where? From whatever source you want. If you are confident that you can answer the questions even with reading Morgan, okay, fine, no problem. And actually some topics you can learn from one book, some topics you cannot learn even from 10 books. So it depends on the topic. So your approach should be topic wise, now rather than book wise. Okay. So there are so many sources, there are books, and especially for people who are going for viva, I will suggest you to have open these links, and you will find so much data with reference to considerations. This they have made, but don't follow each and any single source. This is one thing. Another thing, there are certain viva scenarios you will find it here. Like, I'm just giving you an example, and in the you can find, you can ask any, and you can take any, and you can learn. Like in this, 80 years old is a problem, acute abdomen is a problem, emergency surgery is a problem, atrial fibrillation is a problem. Okay, and urinary retention is a problem. Here there is breathlessness, so you have to find out the reason. Okay, so you can learn so many things from any scenario. Open any scenario and you will find so much learning of thing. How would you optimize this patient for surgery? This is an emergency surgery. You don't have so much time. Okay, but still what you can do, you can have a 12 lead ECG, number one. You can have a history of, with reference to atrial fibrillation. You can, if there is a facility, you can have a quick bedside focused echo if there is any time. But if there is emergency laparotomy and they are thinking any perforation, you will not say that I will send the patient for echo. No, it's not possible. Only to rule out the problem. So this will be a high risk patient. So you will only arrange the ICU and you will start the case, because if you delay, the mortality will increase. Okay, so I'm just giving you an example. So you can open any. There are so much things which I have arranged here. You open it and have a look. And anything you don't understand, you are welcome to ask. Somebody was asking about the consultant. For Saudi Arabia, if your question was, this is some sources which are there in the list. These are the questions which they used to ask in the consultant exam. And I used to create questions, or because even when I was studying, when I started passing, my approach was question based. So if you want to learn, create questions. And this was the quotation of a very learned teacher, Dr. Sajid Usman Kaul, that if you read a page of a book, okay, and you um, learn, sorry, you are able to make a question out of it, you know the subject. I am putting my WhatsApp number here. Okay, anyone who has got any question or want anything, you can drop a message. I'm available to all of you. Okay, so I will be finishing my discussion here, and thanks a lot for your time. And my request, because I again tell you that my YouTube channel is not a monetized one, okay, and it's not for anything for my personal gain or my personal benefit. It's all for you. And I will just show you. There are so many Google Drive links which I have made. Here you can go here in the playlist. Okay, and just a second, where are the playlist? So in the playlist you will find all the topics arranged. Okay, so with reference to viva, here you will find a lot of data. Unfortunately, majority discussions here are in English, but some of them are in our native language. So you are welcome to ask, or if you want me to discuss any topic, you are welcome anytime. There are so much material about career counseling, regional anesthesia, pediatric anesthesia. I have discussed a number of cases like that, viva practice, blood. I will request you to have a look on this page, okay? Because I have done system wise separately, all like pregnant patient for anesthetist, pediatric patient for anesthetist, renal disease patient for anesthetist, liver disease patient. I humbly request you to listen. You will learn a lot. This is again, I request you. This is not for views. My channel is not monetized. So don't think that I'm offering you that I will get anything extra out of it. This is for you. But this is how you should be planning your answer. This is how you should be planning your answer. This is the only way you can survive. Otherwise, if you are just reading the books, you are not able to. Okay. So I have done so many things. So this is if you like you are going for MCPS Viva, but I guarantee you, or FCPS or FCPS Viva, believe me, if you read about it, this is a list. You can say this is a code words or cracking for all the Viva. This I have done discuss in details about preoperative assessment. And this is like, for example, if it is a cardiac patient for anesthetist, it is involving from the history to the conduct of anesthesia. Similarly, respiratory disease and liver disease and renal disease and pregnant patient and pediatric patient. And okay, so I will stop here. And I have mentioned my number. So any one of you want to ask any question before I finish, you are welcome. And otherwise, I will finish. I have put my number here. You all are welcome to contact me anytime. Okay. So should I finish? Any comments or any question? Okay. So now individually, if you have any question, you are all welcome. In the Viva group, I will request you to create a question, start a scenario, start speaking out. You all are mature. You please don't have any shyness. Please don't have any hesitation. Just be very open. Just try to speak out. If you are still reluctant, oh, I will ask something wrong and people will make fun. You are not 5 years old baby. Okay, even if they make fun, no problem. And the beauty thing is that we cannot and enter through the mobile to make fun of you. So don't hesitate, please. As much as you will expose to speaking, if you are not able to speak out in Viva, reading is useless. People who read a lot, Alhamdulillah, I have failed so many times that I am very experienced in failures. And one thing I can guarantee you, examiners have nothing for you. They are not your relative. They are not your enemy. They are not there to fail you. and they are not your beloved that they will pass you. Even if you are not telling anything, they are saying my beloved is very shy, so I will pass because I love him. No, it will not happen. So if you will not tell, you will fail. If you tell, they will never fail you if you are able to convince them. And last few points: be confident, have a eye contact, sitting, don't sit like a what I used to do. Don't sit like an insect. Sit confidently with straight shoulders, looking in front of the examiner. Be don't I'm not saying that go to the beauty parlor, but at least clean yourself, go look very smart. It's look like a consultant. If you are not looking like if you have a beard, trim your beard. Don't go like that. Don't go in an ugly way. Wear a very clean dress. Wear a very whatever you like. I'm not saying that they will look at your beautiful tie or they will look at your khadi dress and they will pass you. No, but at least look very nice. Okay. So thank you very much. I will stop here. And again, remember one thing: the day of your life, if you don't learn or you don't teach, that day of life you'll waste. Okay. And the best way to learn is to teach. Start teaching. When you teach, you will learn. I'm I am a person who used to fail a lot. And if Allah has made me speak like this in front of you, believe me, it's a miracle. I will say miracle. And this miracle has only come with hard work, no doubt. But the day I started teaching, my knowledge increased. Believe me, I was not like this maybe 10 years ago. But as much as I have spoken out, so I will request you the same. Please try to teach wherever you are. Try to help others wherever you are. I don't have anything to get from you. So please make this passion that help out others. If you will help out others, God will help you. Please, if you can, my tab, if you can send a WhatsApp message to me, I will add wherever you want. Okay. So thank you very much. I will finally stop. You will say that I'm like a wrong call. I'm not finishing the call, but I'm talking and talking and talking. So I'm writing the number last time. If anyone that has not noted down, you all are welcome. Thank you very much. Bye bye.